So thank you very much, Miguel, and thank you all for attending. And I apologize because I mismatched the time zones. This happens frequently when you have several different webinars in these times. However, I first of all want to congratulate my co-chairman, Jose Divino and Jose Muraneto, for the publication of this book, because I think it is something that was really needed, especially not for us, but for the future generation. We have lived, and when I mean we, I mean people like me. We lived in nephrology on the last 45 years. We have lived an interesting evolution of nephrology from few people passionate about this subspecialty of internal medicine. We have seen flourishing departments. We have seen flourishing schools of nephrology with many pioneers in different areas. And I would say that in the decade between 1980 and 1990, probably we have seen the peak of evolution and development of nephrology schools and departments. I think this was mainly driven by the evolution in technology, in dialysis, and also the possibility to finally make a very nice and detailed diagnosis with kidney biopsy and histopathological analysis. Coming to the subsequent decades, we have seen a progression towards different subspecialties and disciplines of nephrology, including genetics, including special pharmacological approach, and also the area that I particularly like, which is critical care nephrology. Now, the question is, we have seen in the last 10 years, however, a sort of decadence in the spirit of research in nephrology. And in different countries, we have seen nephrology becoming part of Department of Medicine, with dialysis becoming like a commodity, and peritoneal dialysis almost no research in the last 10 years, and very few important advances. And I think that this is partially due to a kind of, let's say, the fact that our very good fellows very often take other specialties, including intensive care, including cardiology, including infectious disease, including different specialties that seems to bring innovation and important, let's say, new knowledge that allow new areas of research and new areas of interest. I think that this is dangerous because the nephrologist is the last real internist in the world, is the last real internist in the hospital, is the person who knows about pathophysiology more than anybody else probably, and should continue this type of, let's say, mission that was carried out for many years by the nephrologist within the hospital. Now, we probably thought for many years that glomerulonephritis, that has been declared rare disease recently, could pay the bill of large hypertrophic nephrology departments. This is not the case. If we don't have an alliance with industry and development of new technologies, we may end up in a specialty that will be a kind of second class. This is my thought, and I am sure that many of you probably will not share this view, but I am trying to push the young fellows to create new areas of research and to push for new interest in different disciplines. The other thing is, inside the hospital, if we leave the vascular access to the vascular surgeon, if we leave the peritoneal catheter to the general surgeon, if we leave the lithotripsy and treatment of lithogenic syndromes and renal calculi to the urologist, if we leave hypertension to cardiologist, and if we leave dialysis to technicians, then we lose a lot of our power of knowledge in our specialty. And I think we should instead gain space, and space is gained specifically in areas where the contribution of the nephrologist can be crucial. Just look at the, for example, model we have.
Marcelo.
Just look at the model we have developed over the year that around the world is called Vicenza model, where basically all the critical illness concerning extracorporeal therapies in the septic patient, in the acute kidney injury, and in patient with liver failure is completely managed by the nephrologist. In Vicenza, this has been true because since the beginning, we wanted to develop a discipline called critical care nephrology that was basically assigned to nephrologists to take care of. The same can be true for cardiorenal syndromes. I think in hospitals we should do and should force the cardiologists to work together on a specific clinic for cardiorenal patients. And there are now more and more papers, and you may see that my mission in the last years was to publish the links between kidney and other organs. For example, lung and kidney, brain and kidney, liver and kidney, and so on. And I think that we cannot just let it go and keep only attention to our chronic patients, because chronicity not only is a pain on the neck for the healthcare systems, but also it implies that the maximum attention should be given to reduction of cost of the treatment of these patients rather than improving technology. So my advice is for young fellows, please study the mechanisms of dialysis and study the history. How did we arrive to today's technology? Technology was developed through a series of studies that you should know and learn in order to improve further. We expect from you guys, from younger guys, to further explore new avenues. We definitely have succeeded to keep patients alive in dialysis for years, but we're not satisfied. They are not so good. They are not doing well after 20, 30 years. So we need to improve this. Maybe we can improve biomaterials. We need to improve genetic phenotyping of the patient. We need to study more pharmacological approach combined with artificial organs. We need to study the physiology of the interaction between different artificial organs. We know about the organ crosstalk at the physiological level, but we need to learn about artificial organ crosstalk. We need to move towards portable device, wearable device, even implantable device, because mobility and freedom and dehospitalization for our patient will be the future. And definitely, we need to follow the steps of the pioneers in histopathologic analysis in order to prevent with the pharmacological approach the fact that patients evolve towards what we call today endothelial to mesenchymal transition towards fibrosis and end-stage kidney disease. Finally, I would like also to recommend a refinement in diagnosis. For many years, we have diagnosed AKI with oliguria and creatinine. We need to use biomarkers. It doesn't pay to be skeptical about biomarkers. I know they cost more than creatinine, but in our hands, for example, biomarkers were able to reduce 20% of the patient going into continuous renal replacement therapy in the ICU. So if you diagnose early AKI, you may do something to prevent and protect further derangement in the kidney. You also may study the evolution of the acute kidney injury syndrome, trying to facilitate healing of the kidney and restoration of kidney function. And we have also to develop a post-AKI clinic, because many of our patients with AKI end up with loss of renal functional reserve. People just measure GFR, or they estimate GFR, but they have no clue that reduction in renal functional reserve may actually have lost more than 50% of the nephrons without an increase in serum creatinine. And this is an extremely important area of research. So we need to study more the native kidney, because we know something, but we don't know everything. We need to study more the artificial kidney, and we need to study more the interaction with other specialties, which include a kind of humanistic approach. Technology is not just the final, ultimate, and only solution. It is true that you can probably be helped by artificial intelligence in diagnosing early AKI or other disease, but artificial intelligence and information communication technology should not be a substitute for brain thinking. And believe me, young fellows should learn to talk to each other, to learn from each other, to listen to the pioneers, to listen to the older colleagues, to be collegial in the decisions, and possibly sometimes to have a little less internet and a little bit more cabinet, together with the friends, sitting down in a couch and discussing about future plans of nephrology. Nephrology is an interesting discipline. It is a very high-tech specialty, but we are still taking care of the whole body and the whole patient. And the final recommendation for young fellows is that there is a difference between curing a disease and taking care of a patient. Thank you.